દોઢ પોણા 2 કલાકમાં થશે અને Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. In continuity with the previous series in treatment of diabetes mellitus, today we'll be talking on one of the very useful topic, that is insulin. What are the uses? What are the action? What are the different regimes? What are the doses? And what are the different types of preparations which are available in market at present? So we'll be talking on insulins. You can see these are all the different types of preparations, injectable forms which are available in different types. This is insulin patch, and there are different types of preparations, right from Rhizodec, Novolog, simple insulins, analogs, etc. Yes, my speech may not be like these famous people, but I'll try to make it as simple as possible and try to make it interesting. But that at the same time, I'll be talking of all the things which are documented in different literatures. So I'll be talking regarding facts, but not like these people. This is out of way. Any drugs we mainly require for cure of the disease. So insulin is a deadly weapon. When used properly, it is a life-saving. But if it is used without any knowledge and irrational use, it can be deadly weapon. Definitely insulin cannot cure diabetes mellitus, but it can also produce hypoglycemia. It can control diabetes mellitus, but at the same time it will produce weight gain, and cost of insulin is high. So risk is more, and being risk is more, always you look at the benefits. There are good benefits of giving insulin because it can save the life. It can help in controlling the diabetes mellitus, maybe type 1 or maybe type 2. And because of control, you reduce the amount of mortality as well as morbidity. We'll be talking in next slide. So always you have to judge between risk and benefit ratio. And if benefits are more, it is indication. Risks are more, it is contraindications. So this will work. So on one side, cost is very high, but it is very effective, it is safe, it is convenient, there is a predictable response, and you can use the insulin depending upon the patient concern, and depending on the type of patient, depending upon the complications, etc., you can utilize the insulin and give the best control. We don't want this thing to happen. Amputation followed by a prosthesis, or we call artificial foot. There are a lot of complications we call microvascular complication, macrovascular complication. We don't want any one of these complications to occur, because that will increase the morbidity as well as mortality, and also it will affect on the cost factors and economy, and also burden on the society. So there are a lot of complications. We don't want any one of these complications to occur. So even 1% of HbA1c reduction will reduce the death in diabetes by 21%, microvascular complications of kidney and eye by 37%, myocardial infarction by 14%, incidence of amputation and peripheral vascular disease by 43%, and strokes by almost 12%. So there's a good amount of reduction in all these different complications just by reduction of HbA1c by 1%. But say if you get a very good, nice control, rigid control, you will have much better reduction in all these complications. So that is our main aim. So we'll be starting with introduction, followed by action of insulin, different types of insulin, what are the different modes of delivery, what are the side effects, and then we'll go to indication, contraindication, how you select insulin, what regime you select, how you calculate the dose, how you give it, how you monitor, what are the maintenance goal, and what you do in monitoring. So we'll be talking of all this, and then we'll be going to what we call as the guidelines. So insulin is a natural hormone created by nature, not by the drug company. And this is being manufactured by pancreas. We call beta cells of pancreas. It was being diagnosed by Banting and Best in 1921 in Toronto. And then later on the insulin preparation came in market. So 1922, then in 23, Novo Nordisk started manufacturing insulin. In 25, the insulin preparations was further being modified, and we had different types of insulin preparation, then Hodgins, then Hagdons, then different companies came out. Then you can see here, then slowly over a period of time, different types of preparation came in market, and now we have got what we call as human analogs. This was the person who received the first insulin therapy, and after insulin therapy you can see the change. So there was a very good improvement after giving an insulin therapy. Now pro-insulin, then it is converted into pre-pro-insulin is converted into pro-insulin, and then into insulin. This contains A, B and C chain, A chain, B chain and C chain. When that C chain is delinked, pro-insulin becomes insulin, and this is bound by disulfide bonds. There are chains of amino acid which is bound by disulfide bonds. Alpha cell will secrete glucagon, beta cell will secrete insulin, and delta cell will secrete somatostatin. This is just for introductory part. So beta cell will secrete insulin, alpha cell will secrete glucagon, and delta cell will secrete somatostatin. So pre-pro-insulin will be converted into pro-insulin, and then pro-insulin will be converted into insulin. So alpha cell is almost 20%, beta cell is 75% mass, delta is 3 to 5%, G cell is only 1%, and there are some called F cells. This F cell will secrete pancreatic polypeptide, and G cell will secrete gastrin. So these are the different secretions from pancreas. At present we are interested in beta cells, which is going to secrete insulin, and when pro-insulin is converted into insulin, C peptide is being separated out, and also beta cell will secrete amylin. We are not going to talk about those particular things. So whenever a person takes a food, L cells will secrete GLP-1, which will stimulate pancreas beta cells, and insulin secretions will be increased. Glucagon secretions will be reduced. At the same time, you will have a satiety center being stimulated and person will feel satiety. Gastric motility is also reduced. Now this insulin now will act on different cells and glucose will enter into the cells. But what is happening at the beta cells? This is roughly being explained here. As soon as the person takes meal, glucose is absorbed. That glucose will be entering into beta cell via GLUT2 receptor, and glucose will now be metabolized by glucose 6 phosphate pathway, and there will be formation of ATP, and this ATP will now stimulate ATP potassium channel and you will get depolarization. And as soon as the beta cell is depolarized, calcium will now enter inside. So calcium channel will open, calcium will enter inside, and the vesicles which was storing insulin, now that will be released into circulation. This is in short. There's a second diagram you can see. Glucose enters via glucose 6 phosphokinase, Krebs cycle, ATP production. That ATP will stimulate the potassium channel. This potassium will now trigger what we call as a first phase, second phase, and then that will amplify. Calcium channel will open up, calcium will enter inside, and it will give rise to release of insulin from beta cells. This is little bit in more detail. Now, to maintain a basal glucose level which is constantly present in blood, you require some amount of basal secretion of insulin we call as a background secretion of insulin, which is constantly being maintained, which helps in maintaining our glucose level. And whenever we take meal, say like breakfast, lunch or dinner, now at that time the blood sugar rises. With the elevation of blood sugar, you will have a stimulation of beta cells to release insulin. This we call as a mealtime insulin. So we have to maintain our basal insulin level, and during each meal, whatever extra sugar, to control that sugar, you require a mealtime insulin. This is a normal phenomena which is taking place in our body. So there is a daily secretions of two phases, one background secretion and one with the meal. So you have to know this particular basal insulin and we call mealtime insulin, and to maintain optimum blood sugar level. So whenever you give insulin, now as soon as the insulin is given, this elevated fasting hyperglycemia, this is a normal fasting glucose level which is being required, and you require minimum amount of insulin to control that and maintain that level. Now as soon as you give insulin, that basal insulin will reduce the fasting level, will bring back to the normal fasting glucose, and as soon as that is brought down, the postprandial level will also come down to some extent, and with depending upon the meal, there will be elevation of the glucose, and you will require a bolus or a oral drug to control that postprandial blood sugar. So the role of basal insulin is to maintain fasting level. So glucose cannot enter into the cell unless insulin open up the receptor. So it acts as a key at the level of receptor, and glucose will now enter into the cell, and this is done by GLUT4 receptor in different cells. And once that is opened up, now glucose can enter inside, and this glucose will now be utilized, and once it is utilized, now you will get production of energy. Also, insulin will stimulate glucose transporter. It will increase protein synthesis. It will increase lipid synthesis. glycogen synthesis, and it will also have growth and gene expression. This will be the effect of insulin. We'll be going through the next slide. So on adipose tissue, it will increase the glucose uptake, lipogenesis, and decrease lipolysis. As well as on muscle, it will increase glucose uptake, glycogen synthesis, and protein synthesis. While on liver, it will decrease gluconeogenesis, decrease glucose output from liver, increases glycogen synthesis, so storehouse of glucose in the form of glycogen is increased, and it increases lipogenesis. So this will be effect on liver, and together action on adipose tissue, liver as well as striated muscle, it reduces the glucose level. And there will be additional effect in the form of protein synthesis, glycogen synthesis, and lipogenesis. So this will be the net effect of insulin. So on muscle, on liver, and adipose tissue. These are the three main areas where it will be having maximum action. Together, if you see, it increases the glucose uptake in adipose tissue, glycolysis, glycogen synthesis, protein synthesis, and shift of potassium intracellular. So it will produce hypokalemia. You have to keep a watch on that. And it will inhibit gluconeogenesis, glycogenolysis, so output of glucose from liver will be reduced. It will also stop lipolysis, and it is stimulating lipogenesis. So that will be also one of the factors which increases your body weight. And it stops ketogenesis, and it also stops breakdown of protein. So all these together are beneficial effects. But only one drawback, that is lipogenesis, will increase your body weight, increases your fat contents. So weight gain, and if it works in excess, it can produce hypoglycemia. So these two will be major side effects. So whenever the glucose level increases, insulin level will increase, and whenever the glucose level will fall, glucagon level will increase and insulin level will reduce. And this is how the homeostasis of glucose is being maintained. At your leisure time, you can go through. This is in short given how glucose homeostasis is being maintained. So in case of hyperglycemia, glucagon will be inhibited, insulin secretion will be stimulated. And in case of hypoglycemia, glucagon production will increase and insulin secretion will be inhibited. So on one side, you have got insulin, like our honorable Prime Minister, and we have got lot of, we call opposite parties, like glucagon, growth hormone, cortisol, epinephrine, thyroid hormone. All this tries to elevate the sugar level, and insulin tries to maintain the sugar level at optimum level. So together, incretin, that is GLP-1 with insulin. GLP-1 will be acting on pancreas beta cell, increases the production of insulin, decreases glucagon, decreases motility of GI tract, satiety center, etc. Together, it helps in control of sugar. So incretin with insulin are on one side, and these are all the other hormones which we call antagonist hormones on other sides. So insulin secretion will increase with increased blood sugar, with increase in free fatty acid level, increase blood level of amino acids. Gastrointestinal hormones will also, so increase insulin secretions. These are all the factors which will be playing a role, and decrease insulin secretion will be with decrease in glucose level, fasting. Somatostatin will also decrease the level of insulin, and alpha adrenergic activity and leptin will also decrease the insulin production. While all these factors will increase your insulin secretions. So you have to be aware of all these things. And normal physiology wise, physiology of insulin secretion suppresses the hepatic glucose production, and then it facilitates the peripheral glucose uptake, and it suppresses lipolysis and lipogenesis, as well as it also suppresses protein breakdown. So whatever we take in a food form, glucose will stimulate the release of insulin from beta cells. That insulin has to pass through liver, and then it will have effect on adipose tissue, muscles, and all peripheral cells. And also it will give a signal to the brain, and that is how normal physiology is taking place. While when you give from external source, we call exogenous insulin. Exogenous insulin directly bypasses this liver, and it elevates the blood level, and directly it will be acting on the adipose tissue, muscle, as well as liver. So this will be a direct action. So directly it will be acting on the adipose tissue, muscles, liver together. It will bypass liver metabolism. So what is happening in a normal person? 50% of the insulin is removed when it passes through the liver. So liver will create almost 60% of endogenous insulin, and kidney will clear other 35 to 40%. But when you give exogenous, as it bypasses the liver, only 30 to 40% will be cleared by liver, and 60% will be cleared by kidney. So that is a little advantage of insulin. Half-life of endogenous insulin is very short, 3 to 5 minutes. And basal insulin, when you give, it will produce a longer half-life, and that will be helpful. Insulin will be metabolized by a protease enzyme. In type 1 diabetes mellitus, lack of insulin will increase catabolism and decrease anabolism. By decreasing the anabolism, hyperglycemia, glycosuria, osmotic diuresis, salt and water depletion, we call dehydration, and negative fluid balance, as well as it will increase the secretion of glucagon, cortisol, growth hormone, catecholamines. All this will again increase hyperglycemia. And increased catabolism will produce glycogenolysis, gluconeogenesis, so that will start producing wasting and loss of weight. Increased lipolysis, increased ketone formation, acidosis, hyperventilation, peripheral vasodilatation, hypotension, hypothermia, and this will end into what we call as a diabetic ketoacidosis. So dehydration, electrolyte imbalance, and ketoacidosis together, if not diagnosed early and if not treated early, can end up with death. And this will happen because of lack of insulin. Same thing can happen in a type 2 diabetes mellitus when insulin resistance becomes tremendously high. Insulin cannot act on the peripheral tissue like muscles, adipose tissue, etc. And if there is an excess of ketone production, person can end up with diabetic ketoacidosis in even type 2 diabetes mellitus. Now this is the showing you different types of insulin, how it has advanced. In 1922 it was first isolated by Benting and Best. Then from animal preparation, that is pork and beef, animal insulin preparations were available. By 1977, now recombinant human insulin was being manufactured by DNA technology. Then you got rapid acting insulin analogs, biphasic insulins like Novomix. Then basal insulin analogs were being invented in 2000. This was in 1990, this was in 1977, and then onwards. Now in 2013 degludec, which is the longest acting basal analogs which is available, and now we have got insulin degludec plus combination of other materials, etc. Will be showing you all those things. So this is a different types and varieties of insulins. So right from the 1922, protamine means animal insulin, then we got intermediate acting insulin like protamine zinc insulin, then NPH, then lente insulin, then glargine, datimer, then glargine 13-1, 300 unit per ml in 2015, and now in 2017 degludec came in market. So these are newer and newer things are getting available. Now we have got even degludec 100 and 200. We have the glargine which is 100 unit per ml and 300 unit per ml. Plus we have got combination of degludec with short acting insulin we call the premix insulin, etc. Now this insulin analogs, we want a better safety profile, more dose flexibility, less weight gain, etc. And that was being provided by modern insulin, we call as insulin analogs. And these were labeled different names. Now we use the word insulin analogs only. Previously they were calling designer insulin, insulin receptor ligands, democratic insulin, etc. These were the words which were being utilized. And these particular analogs used to reduce hypoglycemia and diabetic complications were reduced because of improvement in glycemic control, and being a dose flexibility, the person compliance was improved, glycemic control was better, so diabetic complications were better. So we have got different types of preparations right from animal preparation. Now those are totally out of market. We have got human regular insulin, human NPH. We have got different types of pens, refills, etc., which is containing rapid acting insulin, intermediate acting insulin, long acting insulin, and further now we have got ultra long acting, ultra rapid acting insulins. We have got a premix insulin. We have got combination of basal plus GLP-1 we call as a combo pack, or we call co-formulations like degludec with liraglutide or glargine with lixisenatide. These are all the preparations, and depending upon the onset, peak of action and duration, we put them into rapid acting, ultra short acting, ultra short acting, intermediate acting, then long acting, ultra long acting insulins, premix insulins, etc. And they are available in the form of pens, smart pens, syringes. Now oral preparations are also under different phases of trials, and sooner or later it will be available in market. Then they are trying for rectal preparations also. There are already inhalers which are available in the form of what we call as inhalers, different inhalers, Afreza. We'll be showing you that slide. There are transdermal preparations which are available called as a transdermal patch. There are also smart insulins. Artificial pancreas is also available, which is containing Biocon, which is having both, that is insulin plus glucagon in two different chambers. So that is called artificial pancreas. Smart things are available in that. So that is called Bionic Pancreas. We have got ocular, they are trying in ocular preparations, etc. So we have got short acting insulin, rapid acting insulins, analogs, and we have got ultra short acting preparations like FIAS. Intermediate acting like NPH, premix insulin, which is a mixture 70-30, 70-25, etc. We'll be showing you some of the slides. Basal analogs like glargine, which is 100 unit. Then we have got glargine biosimilar, which is called Basiclar. And we have got datimer, which is available as Levimer. Also we have got degludec. Then we have got ultra long acting basal insulin in the form of glargine, which is U300. These are all the different types of preparations which are available in market. So these are the just name introductory part. So when a long acting insulins are there and short acting insulins are there, we divide into two big groups. When short acting insulins, they have to be given at meal time, or we call prandial insulins, or mealtime insulins, or we call bolus insulin. Now we always use the word bolus insulin, means with each meal you have to give those because they are very short acting insulin. We'll be showing you in further slides what is the duration of action. So they are available as human insulins in the form of, we call human regular insulin, Humulin R, or Actaprid, or Insuman Rapid. These are the three common preparations which are being available. And as far as analog is concerned, Lispro, Aspart, and Glulicin. Glulicin is Epidra, Aspart is Novorapid, and Lispro is Humalog. So these are the three companies. Those preparations are available. We call that as the analog, and these are called human regular insulin, which is Actaprid, which is human regular, Humulin R, that is Eli Lilly, and Insuman Rapid. These are the human preparations. Means regular, we label them as a regular. So these are different from analogs. Now these are also called short acting insulin. So these are short acting insulin, these are called rapid acting insulin, because depending upon the period, that is onset, we have already told you, onset, peak action, and duration of action. You divide them into short acting, rapid acting, ultra short acting, etc. So these are the words which are being utilized. We'll be showing you in slides. And this particular can be given subcutaneous, or in case of emergency, you can give in a IV drip form also. So these are the preparation which you can utilize in IV drips. You can utilize analogs, you can utilize human regular insulins in the form of Actaprid. This is a common. So short acting insulin, rapid acting insulin, and Fias is ultra short acting insulin. So bolus insulin has to be given with each meals, and even if the person is taking snacks, you will require bolus insulin. So it is also called rapid, bolus, mealtime, or prandial, or also short acting insulins, ultra short acting insulin. These are all the terminology which are being utilized. Rapid acting insulin should be acting just like our natural secretion of insulin, and that's why they almost match the absorption of carbohydrate from typical hospital meals, and there is a fast onset and short duration. So it is almost acting like our natural insulin secretions. So you have to give with each meal, and if they are ultra short acting, you can give just before you start a meal, or immediately after meal also you can give. So it is very easy to coordinate the insulin administration with food intake if they are ultra short acting, and one of the ultra short acting is Fias. And because of that, there is a less chance of hypoglycemia. Better glycemic control is with ultra short acting insulin, short acting insulin, and then we call rapid acting insulins. So for fast acting insulin to become an ultra fast acting insulin, you will have to utilize which should increase your absorption. So you try to use the material which can increase your absorption. So there will be something which will help you to increase the absorption, and also technology which increases your absorption, like application of it, or hyaluronidase, or addition of citric acid, or citrates, or biochaperones, or niacinamides, etc., which increases the absorption, or mode of giving. And these are the different types of preparations which are available. We call ultra fast acting insulins formulations. by bichaperones Lispro, then treprostinil Lispro, and fast-acting aspart, that is Fias. These are the different preparations which are being available. And there are also insulins available in 100 unit per ml, 200 unit per ml, because the person who has got an insulin resistance will require a very large dose of insulin. The quantity will be more. So to reduce that amount, now there are preparations of U500 also of regular insulins, which are already successfully given in person with obesity, immune mediated insulin resistance, and person with genetic abnormality of insulin receptor. In near future, we will have U500 insulin also available in Indian market also, sooner or later. Then we have got what we call as a basal insulin, which are long-acting insulin. We have got two types of preparation we call human preparations like NPH, which is available as Humulin N, Insulitard, and Insuman Basal. And we have got other type of preparation we call analogs, which is in the form of glargine, which is called Lentus. Now Lentus is available as 100 unit and 300 unit. 300 unit is called Tozio, which is available as 1.5 ml, which contains 450 units, while this Lentus is available as 3 ml, which is containing 300 unit because it is 100 unit per ml. Datimer is available in the form of Levimer, and Degludec is available in the form of Tresiba, which is available as 100 unit and 200 unit. And this particular is called basal insulin or longer acting insulins. This has to be given by and large at bedtime, cannot be given IV. It is mainly as a subcutaneous preparations. So these are to be given best at bedtime, or we call after dinner. If dose required is more, you can split up and give it BID, but by and large they are very long acting insulin, so they have to be given OD. So basal analogs at dinner or at breakfast, depending upon the convenience, and every day at fixed time, same time, say 9 p.m. so every day 9 p.m. so that should be there. Why we need this basal insulin? We need a basal insulin for clinical benefits, for control of fasting glucose with one injection per day. We want lower incidence of hypoglycemia, and we want lower hypoglycemia as well as hyperglycemia. So to reduce all this, to have all this beneficial effect, we need a basal insulin which is having a longer duration of action and no peak. So flat level. And this is by engineering the insulin analogs in hexamer preparation. Multiple hexamers is converted into dihexamer, then monohexamer, then dimer, dimer, and finally into monomer. Monomer are available in Novorapid, so they are short-acting insulin, while in a Levimer they are either as a dihexamer or multihexamer. So highest amount of multihexamers, which if they are present, they'll become the longest acting insulin, while if the insulin preparation is containing monomer, they will be rapid acting insulin, because this monomer will be easily absorbed and will be available in blood, and this technology is being utilized. And to make it more compact, 100 unit per ml will occupy more space, but if it is 300 unit per ml, it will occupy less space, and being occupying less space, the depot surface area is reduced, leading to slow release, as well as the effect is longer. So two benefit: surface area is less, slower release, and longer duration of action. Hence, this is also called as ultra long acting insulin. that is glargine, available as Tosio. So that is the thing, and it is almost parallel to degludec U200. So this is the benefit of having what we call as more unit in small area. So 300 unit in small area will be giving rise to ultra long acting insulin. So we have got glargine available as 100 and 300. Basiclar is available only as U100. Datimer is available as U100 only. Degludec is available as U100 and 200. So human insulin, which are intermediate acting, is available as U100 only, and those are humulin and insulitard and insuman basal. Long acting analogs like glargine is available as 100 and 300. Datimer is available as 100 only, and biosimilar glargine is available as 100 only, that is Basiclar. While ultra long acting, that is U300 glargine, is available as Tosio, and degludec is available, which is already a longer acting insulin, and it is available as 100 and 200, which is available as Tresiba. So these are all the different types of basal insulin which are available, and there is a very marginal difference between glargine U300 and degludec 200. You can just go through here at leisure time. The onset of action as far as glargine is concerned, 6 hours. This is 1 hour. Peak is flat in both. Half-life is nearly same. Degludec will be acting for 2 to 3 days steady state, while glargine will have almost for 4 days. So effective duration is almost more than 36 hours, while this is up to 42 hours as far as degludec is concerned, because it is basically the preparation is such, it is an ultra long acting basal insulin. So that are the words which are being utilized. Now there are preparations which are already in a trial called insulin isodec. Now this particular insulin isodec is having an effect for a very long period. So we have got the ultra fast acting analogs, which is utilized in pumps and closed loop system. We have got compact preparations in the form of 300 per unit, 500 per unit, etc. We have got a very long acting basal analogs like degludec. This is degludec, or we call Tresiba. And now we have got preparations which are acting for almost 1 week. So it will be useful for both type 1 and type 2. So this is called icodec, which is once weekly, and in near future this will be one of the best preparation available. So person will have to take once weekly. It is action is lasting for 168 hours, so almost for 7 days, and less chance of hypoglycemia, a good compliance, all those benefits are there. To have basal and bolus effects, so long acting effect as well as short acting effects. Now premix preparations are being available. We call 70-30, where 70% is long acting, 30% is soft acting, in the form of humulin 70-30, mixed-start 30, or insuman combo 30-70. These are the preparations which are available, where human insulins are being available, human preparations are available, while in analogs it is a mixture of long acting analogs and short acting analogs in the form of Novomix 30-70, Novomix 50-50, Humalog 25-75, and Humalog 50-50. These are the different types of preparations which are being there. This has to be given only subcutaneous. We can never use IV. So this you have to keep it in mind. These are called premix insulin, which will have to be given before breakfast or before lunch or before dinner. It cannot be given in the form of OD preparations. Good number of time it has to be given along with oral hypoglycemic agents, or maybe a 2 dose or 3 pricks, 2 pricks or 3 pricks. So it has to be given at dinner or at breakfast or at lunch, depending upon which you want to control. So these are the different NPH regular contains rapid acting, NPH regular will contain 70% of NPH with 30% of regular insulin, and they are available as Humulin 70-30, Doxulin 70-30, Mixtard 70-30, etc. While analogs, rapid acting analogs with intermediate acting analogs, that is rapid acting aspart with intermediate acting aspart, and that is available in the form of Novomix, Humalogs, 30-70, 25-75, 50-50. So these are the different types of preparations which are there. So Novomix will be 30-70 of aspart and aspart protamine. Rhizodec is a combination of degludec with aspart. Degludec will be 70, 30% will be aspart. Humulin will be 70-30, that is 70 of NPH with 30 of regular insulin. Or even another name is Mixtard, we call Mixtard 30-70. Lispro with 25-75 or 50-50, that is Lispro with Lispro protamine. And now there are preparations which are with GLP-1 receptor agonist. So these are called Premix Insulin. These are called co-formulation, where you got the two different preparations available in one syringe. That is Basal Insulin, which will be a long-acting insulin plus GLP-1 receptor agonist. So these are called co-formulation. There are the advantage. This has got different type of action. This has got different type of action, and both are synergistic. They are available as Ideglira and Lixilan. So these are the two types of preparations which are available as co-formulation. So we have got insulin Rhizodec available as mix insulin, which is degludec with aspart, So aspart is 30, degludec is 70, and this is one of the degludec is very long acting insulin, and this is short acting insulin. So this can be utilized as a mixed preparations and to reduce the number of pricks. So this is indirectly one variety of a mixed preparation. But one thing you have to keep it in mind, it is not recommended for type 1 diabetes mellitus. Absolutely not good for type 1. Still, we do try these preparations to reduce the number of pricks. I have tried in few patients. I am getting benefit. I have not seen much amount of side effect in the form of hypoglycemia. As far as type 2 is concerned, if well controlled, continue with the same mix insulin. Don't mix glargine with datima, because both pH are different. So this glargine should not be mixed with datima. NPH and regular acting insulin mixing, if you have done from a separate bulbs, it should be utilized immediately. And rapid acting insulin like Lispro, Aspart or Glulosin, when it is mixed with NPH, it should be utilized within 15 minutes. So best is ready-made premix preparations are better than mixing it and then giving. As well as always keep it in mind, never mix glargine with datima, because datima is a long acting, this is short acting, but the pH of both are different, so it will not suit as far as pharmacokinetic and pharmacodynamic is concerned. So while you are giving an basal insulin with GLP-1 in type 2 diabetes mellitus, you reduce the chance of hypoglycemia, you reduce weight gain, you will increase the adherence, and person will be benefited. So that will help in reduction in HbA1c, postprandial as well as fasting glucose. All three will be benefited, and hence co-formulations are now becoming more popular. And so basal insulin will help in controlling fasting and pre-meal. Body weight which is increased will be reduced by GLP-1 receptor agonist, and relatively high risk of hypoglycemia of basal insulin will be reduced by low risk of GLP-1 receptor agonist. Hence, this is what is called as complementary benefits, complementary effects. And we have got two types of preparation, degludec with liraglutide and glargine with lixisenatide. They are available as Zultofi and Soliqua. That is 100 with 3.6, this is 100 with 33. So these are the preparations which are being available. If you are interested, you can go through the different literatures. So these are called co-formulation. Another way of giving insulin is by in the form of inhalers. So when you give by inhalers, it will be absorbed through the respiratory tract and it will go systematically, will have effect. So 1 milligram of inhaled dose will give you approximately 2.75 unit of insulin, and 3 milligram will give approximately 8 unit of international unit of insulin. But there will be lot of factors which will be affecting the absorption through respiratory passage, and those factors are lung conditions like a smoker, person with COPD, chronic bronchitis, bronchial asthma, lung infection, etc. The absorption will be severely affected, and we don't know how much is absorbed. So chance of hypoglycemia, body weight gain, cough, etc. becomes high, as well as the chance of insulin antibody formation is also increased, and yet we don't know long-term safety. Hence, these are not the preparations which are commonly being utilized. But there are two types of preparation, Exurba and Afrezza. Exubra was being available in inhaler which were of a big size. Now Afrezza is available in a very small type of preparations which is very handy. And if you look at the Afrezza, 4 units, 8 units, different types of Afrezza are available. So you can utilize that. Say if you want to give 24 units, you can give 3 doses from this preparation which is containing green color, which is having 8 units per 1 puff. So this is 4 units. So if you have to give 4 units, you can give this. If you want to give 12 units, so 4 units from this and 8 units, or you can give 16 units, 2 puffs, etc. So these are almost good effective, we call Afrezza, and they are handy. So they are in use, but you have to always keep it in mind, respiratory conditions. Now there are other types of preparations which are being available, that you utilize the basal insulin, or you utilize what we call as a bolus insulin in the form of injections or in the form of different types of modes of giving insulin, like convention insulin pumps, short form it is called CSI, 2I. Sensor augmented insulin pumps, they are with continuous glucose monitoring system, and there are now available automated closed loop insulin pumps are also available. These are the different types of insulin pumps which are being there, which are called continuous subcutaneous insulin pumps, which will be supplied with basal insulin in the form of continuous infusions, with pre-meal bolus also may be available. By and large, they are short acting or with rapid acting insulins are very commonly being utilized in this. There are now insulin patch which are available, we call smart insulin. So you can apply a patch, and that insulin patch will deliver the insulin after detecting the amount of glucose. So it has got the facilities of detecting the insulin level, and they are available in nano particles. So they are working on a nano networks, and these are called smart insulin patch. So they'll detect the amount of glucose level in blood, and they will deliver the amount of insulin. There are other preparations they have tried like albumin, then orally absorbed insulin like Oralin, transdermal insulin patch. We have already shown you there are different types of preparations which are being there. There are oral aerosols they have tried, and they are trying oral capsules. There are internal insulins they are trying, and this is now most probably this will be the new generation insulin available in oral preparations. That is called by SOMA technology. That is self-orienting millimeter scale actuators. So when it is being swallowed in the form of capsule, this will set on the intestinal mucosa in this form, and then it will deliver the insulin, and that insulin will be absorbed, and this will happen. It will first localize, then it will inject, and within 1 hour it will be dissolved and it will go into bloodstream. Now there are other types. Oramed pharmaceutical company has prepared and it is under trial, that is containing a protease inhibitors, and because of that protease inhibitors, that breakdown of insulin is being inhibited and insulin is available in for absorption. There is another group of scientists who are trying insulin in the form of nanoparticles, and that is having multiple layers, and having a multiple layers, that insulin breakdown is being restricted and insulin will be delivered. So this will be another technology by which the oral preparations will be available. And there is one more variety. Geranic acid is utilized as a carrier for insulin, which is resistant to gastric juice and breakdown of insulin. So in near futures, we'll have all this different type of technology for oral insulins. Yes, pancreatic transplants are being done, islets transplant is being done, but yet those are still not very effective. We have got artificial pancreas. We have got islet cell transplants which are being done. They are still under different trials. Near future we might have. We have got artificial pancreas in the form of artificial pancreas or bionic pancreas, where there are two chambers. One chamber contains insulin and another chamber contains glucagon. And there is a continuous glucose monitoring system. And depending upon that, it will deliver insulin, and if person develops hypoglycemia, insulin secretion will stop and it will deliver glucagon. And this is called bihormonal or bionic pancreas. And this is in market since 2018, and it is a wonderful way of delivery. So this is continuous glucose monitoring sensor will send an input to a receiver that will control, and that will be acting on an insulin pump. And if person develops hypoglycemia, insulin pump will be inhibited and you will have a delivery of glucagon. And in a chamber, you got a two separate chambers containing, one chamber contains insulin and one chamber contains glucagon, and this is acting by a closed loop mechanism. So I'm not an expert, but this is just what I've gathered a knowledge. So there is a closed loop mechanism which is being working in this. So after listening to all this, we are bound to get headache. So we are interested in two type of preparation. One we call as short acting preparation and long acting preparations, and we'll be now going through how exactly. Short acting preparation, roughly remember 135. So action will start within 1 hour, peak will be 3 hours, and duration will be 5 hours approximately. And intermediate acting will be 2, 12 and 24. So if the duration is becoming 24, then it becomes a long acting insulin. So action will start after little period. Peak will be 12 hours and 24. Now this does not shoot our glucose excursion after meal. Hence, these preparations are little risky because they are acting for a longer period. In between the two meal, we does not take any particular material which will elevate the sugar. So chances of hypoglycemia will increase, and because of that, the best is basal, and this is bolus. So this is a slide which tells you a very good idea. Say actaprid, which is we call is a short-acting insulin. So you can see the onset will start within half an hour. Peak will be 2 to 4 hours. Duration will be 6 to 8 hours. While rapid-acting analogs will be action will start within 15 minutes. Peak will be 1 to 2 hours. Duration will be 3 to 5 hours. Now what happens here? This is action is starting after 30 minutes. So at least you will have to give half an hour before meal. And peak is 2 to 4 hours. And our glucose peak after meal is highest at 2 hours. So action is still longer. And then duration is 6 to 8 hours. So by the time the action is becoming less, still we don't have a glucose level because glucose level starts falling after 2 hours, and by 3 to 4 hours the glucose level is almost at normal. So the chances of hypoglycemia will be increasing with this type of preparation. So this is better, rapid acting is better, and ultra short acting, that is epidra, which is very ultra short acting, which action will start little early, and peak action is again 1 to 2 hours, and duration is becoming little shorter. So epidra is one of the best preparations which is being available. We call ultra short acting insulin, or we call that is available at FIASP. Intermediate acting insulin, onset will be little later, peak will be 4 to 8 hours, and duration is 14 to 16 hours. So during this particular time, the chances of hypoglycemia will be there because there will be no glucose excursion. And in long acting insulin, this is best because once you give a prick, after 2 to 3 hours, then there is no peak, there is a plateau. And after 2 or 3 days of regular insulin, then this plateau is being maintained. You will not have chance of hypoglycemia. So chance of hypoglycemia will be reduced. And in a premix insulin preparation, you will have a two peak, one because of short acting and one because of long acting. So you will have to be very careful regarding the meals, what is the type of habits what is having. So all those things should be kept in mind. So these preparations has to be utilized with caution. Best is ultra short acting, and we call long acting basal analogs. That's why we call basal bolus. This is basal and this is called bolus preparation. And rapid actings are better than short acting insulins. And again we call ultra short acting insulins are better than short acting insulins. So this is short acting insulin, intermediate acting insulin, long acting insulin, and this is degludec, which is very long acting insulin, or we call ultra long acting insulin. So we have got glargine and datimer as a long acting insulin. Intermediate acting is NPH. Regular insulin is short acting, and relatively short acting, or we call rapid acting insulins, are lispro, aspart, and glulucine. And we have got one more preparation we call FIASP, which is ultra short acting insulin. These are the words which are being utilized. So you can see this. These are already we have shown you here. That is rapid acting, short acting. So can you see that this is regular. These are aspart lispro, which are rapid acting, and you will have a ultra rapid, or we can call ultra short acting insulin. NPH is intermediate acting. There is something called as ultra lente, which will be little longer acting. And then you have got two other preparation, that is glargine and datimer, which are long acting, and degludec will be acting for more than 24 hours. We already mentioned that insulin glargine, which is 300 unit, available in 1 ml, which will be releasing insulin very slowly and effect will be lasting longer. So this becomes nearly ultra long acting insulin, same like insulin degludec. So that is the advantage. Now you can see that 300 is acting for a longer period, almost 36 hours, while this is acting for nearly 42 hours. Isodeg is acting for almost 7 days. Almost 7 days. So that is the action of Isodec. And this is a longest acting insulin available which can be given every 7 days. So that improves your compliance and it will also improve the incidence of hypoglycemia. So there will be less and less incidence of hypoglycemia, compliance will be improved, so glycemic control will be improved and all the complications of diabetes will be reduced. So this is acting almost for 168 hours. We have already mentioned regarding all this: rapid acting insulin, short acting insulin, intermediate acting insulin, long acting insulin and ultra long acting insulin. At your leisure time you can go through regarding onset, peak of action, duration of action. This is same thing is mentioned here. Comparison of NPH, degludec, detimer, glargine and glargine, or we call Tosio, U300. So all those are being mentioned. At your leisure time you can go through. Duration of action, peak action, onset of action. And regarding U500 which is being available, that is of regular insulin, the onset is 30 to 45 minutes and duration is 24 hours. So these are the preparations are now becoming of use. Glargine 300 available at Tosio, almost acting for 24 hours and little longer. Degludec is acting almost for 42 hours and Peglispro is acting for almost 36 hours. So this becomes a longer acting insulin, or we call as a ultra long acting insulins. Now regarding a regular insulin, there are little disadvantages. There is a delayed onset of action, prolonged peak of actions and duration of action. Hence chances of hypoglycemia will increase. So late postprandial hypoglycemia is higher. So always keep that thing in mind and see that you use a proper insulin. So factor which affects the absorption is site of action, type of insulin, subcutaneous flow, hot water bath, exercise, massage, smoking, muscular activity, volume and concentration of injected insulin, all those, how deep you are giving injections, whether it is subcutaneous or intramuscular, all these factors will be having effects. They are available in many different types of preparation. The days of insulin syringe are gone, but still in India, these are some of the preparation. You will have to keep it in mind. While a person is using syringe, see that whatever is mentioned on the bulb, because there are two types of bulb preparations which are available, 40 unit per ml and 100 unit per ml. So accordingly the syringe should be utilized. See that that mistake is not done by you and or by patient. We have got insulin pumps, implantable pumps, insulin pens which are disposable and reusable, jet injectors, inhalers, oral insulins, patch, ocular drops, then continuous infusion pumps, artificial pancreas, bionic pancreas, etc. There are many different ways of giving insulins. So we have got disposable pre-filled pens and we have got reusable pens with cartridge. And right from this was the first which was being utilized for giving insulins. Now we have got a very small size materials which are being available in the form of closed loop pumps, etc. So delivery devices. Adverse effect of insulin is hypoglycemia, weight gain, lipodystrophy, allergic reactions, hypokalemia. These are the most common which are being seen in everyday practice. And the person who gets hypoglycemia will have tachycardia, confusion, vertigo, diaphoresis, lipodystrophy, hypersensitivity, and even lipo atrophy. These are some of the complications. But in hypoglycemia, person will develop a severe tachycardia, confusion, diaphoresis, and vertigo will be very, very common. So hypoglycemia, weight gain, lipodystrophy, local allergy, hypokalemia are the common complications. And insulin, don't forget insulin resistance. So common side effects we have already mentioned here. You can see here there is a lipo atrophy. So even lipo atrophy, locally you can have redness, itching, systemic allergy can be there. Lipo atrophy, hypertrophy or lipodystrophy we call. Insulin edema and weight gain are quite common. And we call insulin resistance and hypokalemia. Insulin shock is because of low blood sugar. Person can have a low blood sugar, that is hypoglycemia, because of overdose of exogenous insulin, or person has taken a regular dose and has not taken a meal, or overexertion without taking additional calorie intake. That can produce hypoglycemia, also sometimes described as insulin shock. This is a picture showing you a lipo atrophy. This is lipo hypertrophy. And at the site, you can have abnormality in the form of lipodystrophy or lipohypertrophy, quite common. Then you can have at the site local reactions. Then scarring and hyperpigmentation at the site of injections. TAP, what is being applied for insulin patch or while giving CSI. Then this is described as a necrobiosis lipodica. So necrosis in a fatty tissue. Hypoglycemia will be very common. I am not going in detail. This will be all the symptoms and signs. At your leisure time you can go through. That is mood changes, tremors, sweating, headache, extreme tiredness, dizziness, blurred vision, pallor, severe hunger, and person can even become unconscious. And the treatment, and because of hypoglycemia, person can have coma, hospital cost will increase, cardiovascular complication, weight gain, loss of consciousness, increased risk of seizures, dementia because of repeated hypoglycemia, quality of life will be affected, increased risk of car accidents, etc. And sometimes person can even have mortality in the form of death. And what is required is, if person is unconscious, you will have to give IV dextrose. But if a person is conscious, then you can give carbohydrates in the form of glucose tablets or soda pops, etc. And then repeat the test after 15 minutes. See the target is reached or not. If it is not reached, you will have to repeat, and you might have to give what we call as, in case of severe hypoglycemia, glucagon. You might have to use glucagon. There are two common other phenomena which you come across while treating a patient of diabetes mellitus, and particularly if they are on insulin. It is much more common. We call dawn phenomena or Somogyi effects. And this you can diagnose only after having a glucose monitoring. Blood glucose level will fluctuate all throughout the day. But by and large, before morning, that is in the morning, before breakfast, glucose level will be euglycemic, means it will be normal. Now, in some of the conditions, particularly dawn phenomena and Somogyi effects, you will have an increased blood sugar level early morning. How exactly it is happening, we'll be explaining that. So, to understand that, glucose regulation is very important. So, insulin will be having an effect on glucose, as well as glucagon, epinephrine and growth hormone will have effect on glucose. These three hormones will try to elevate the glucose, while insulin will try to reduce the glucose level. So glucagon, epinephrine and growth hormone will increase the glucose level. Clear? So as soon as you get the increased glucose level, glucagon and growth hormone will be inhibited. And glucose elevation will stimulate the insulin secretions, while decreased level of glucose will stimulate the glucagon and epinephrine and even the growth hormone. So this will be the effect of level of glucose. In dawn phenomena, there is a nocturnal secretion of growth hormone which is being increased, and because of elevation of a growth hormone production, early morning hyperglycemia will take place. So if you do a blood sugar level in midnight, it will be normal, and early morning sample will show you hyperglycemia. What will be required will be just shifting the timing of the evening dose of intermediate acting insulin from pre-prandial dinner to 2 hours after dinner will be beneficial in dawn phenomena. So just adjusting the dose of long acting insulin, or we call intermediate acting insulin, will be sufficient. While in a Somogy effect, it is because of a rebound hyperglycemia. Because of excess of exogenous insulin, you get hypoglycemia during midnight, that is at 2 a.m. or 3 a.m., and that will produce release of counter-regulatory hormones in the form of a glucagon, cortisol, growth hormone, adrenaline, etc. And you will have a early morning hyperglycemia. Because during midnight, person is not aware of silent hypoglycemia. And this is going to produce rebound hyperglycemia. And that is given a name, Somogy phenomena or Somogy effect. So just understand it. In Somogy phenomena, you will have a hypoglycemia followed by hyperglycemia. While in case of a dawn phenomena, you have got normal blood sugar level, but because of increased action of growth hormone, you have got hyperglycemia at early morning. These are the two phenomena which will be there. So just you have to keep it in mind, and you have to differentiate between the two. So in a dawn phenomena, you will have to adjust the timing of the insulin. While in case of a Somogy effect, you will have to reduce the dose of insulin. You will have to reduce the dose of nighttime insulin. So those are the two simple things what you will have to do. Now we are coming to the second part of insulin. This particular portion I'll be discussing in the second part of insulin, that is indication, contraindication, selection, calculation of dose, how to use, how you monitor, and how you maintain the goal, and what are the guidelines. So thank you all for listening to this. I will be dividing into two series, that is part 1 and part 2. Part 2 will be containing indication, contraindication, all these things. What I have done at present is introduction, action, types of insulin, method, how you give it, what are the different side effects, etc. I have covered that part. In second part, I'll be covering this. So thank you all for taking out time. Go through the second part, and if you like the lecture, please don't forget to press button like. You can share with your friends. It will be very helpful to you in your everyday practice, also in your theory, and also in your oral exams. So I end my lecture here. See you in next lecture.